My name is Zhenya Abbruzzese, and in 2019, I co-founded, or I helped co-found, the Society for Evidence-Based Gender Medicine, or SEGM. SEGM is actually a really boring organization, and we like to keep it that way. We believe that there was a need for a serious scientific organization that is focused on the science and evidence. In my own free time, however, I do a lot of my own research, and one of my areas of interest is the Dutch protocol. Of course, the Dutch protocol is very, very important. You can think of it as the DNA of the practice of youth gender transitions. And last year, I, along with two of my colleagues, Dr. Stephen Levine and Julia Mason, began to take a very close look at the Dutch protocol and the studies that reported its results. What we found was that the studies are so flawed that they should have never been used as the basis for launching what was a small experiment in the Netherlands into the mainstream medical practice that it is today. We published our findings in a peer-reviewed paper, The Myth of Reliable Research, and you can all read the paper. Today, I'll talk a little bit about the findings from our research and the implications that they have for the field of youth gender medicine. But it's also important to remember that the practice of youth gender medicine is a direct outgrowth of the practice of adult transitions. And for this reason, I will begin my presentation with a brief historical overview of adult transitions and what we can learn. It would be impossible to fit the nearly 100-year history of adult transitions into a single slide. But one particular step in that journey, one particular individual deserves a very special discussion. And that is the story of Christine Jorgensen. As Harry Benjamin said, without Christine, none of this would have happened. And Harry Benjamin, as many of you know, is regarded by some as the father of transgender medicine. And he's also the person who WPATH was named after originally and carried his name for a long time until about 2006 when it rebranded into WPATH. So back to Christine. Christine grew up as a boy by the name of George. George was a very quiet boy who preferred reading to rough and tumble play. George went into the Army, and after the Army, he enrolled in a local medical college for a little bit. And then George went to Europe. So after George went to Europe to work, the parents didn't know much about why George was in Europe until one day they got a letter. And I'm going to play with the microphone a little bit. I'm not as tall as most of the speakers. All right. So one day, George's parents received a letter. And the letter began with the words, and now I will read from the letter. My dearest mom, dad, I am now faced with the problem of writing a letter, one which for 2 years has been in my mind. The task is a great one, and the 2 years of thought haven't made the task any easier. I know there are many parents in the room, and you can probably imagine what the letter said. In the letter, George continued, we humans are perhaps the greatest chemical reaction in the world, and therefore it is not strange that we're subject to the very many physical ailments. Among the greatest working parts of our bodies are the glands. Several small, unimportant-looking glands, yet our whole body is governed by them. George, who by then was Christine, and so I will do my best to refer to, from now on, to Christine as she. And Christine, by the way, took the name of her Danish endocrinologist who treated her. Christine told her parents that she suffered from an imbalance in the glandular disorder, that this imbalance was finally corrected, and instead of a son, they now had a daughter. Later, it was clarified that George did not suffer from any kind of endocrine disorder. So the parents did not see this coming, and after the initial shock wore off, they did what any loving parent in their situation would do. They took the letter to local tabloids. And so the story of Christine Jorgensen went viral, at least by the 1950s standards, because this was 1952. So now I will switch to how Christine Jorgensen's Danish doctor, Dr. Christian Hamburger, described the situation in his own words. Even before our patient had been discharged from the surgical clinic, the news of the change of sex had spread all over the world. In record time, the news had reached the remotest corners of the earth, and since my name was quoted in the reports, letters began pouring in. Between December 1952 and October 1953, I received 1,117 letters from patients. So, Dr. Hamburger loved taking care of his patients, but he also loved data. So what he did with the letters after he read them is he analyzed them, synthesized them, and published them in a peer-reviewed or a scientific article. I'm not sure if it was peer-reviewed. So the study, and you can read it, it's available, revealed some interesting findings at the time. Now they're not very surprising. There were 3 times as many men as there were women who contacted him. The motivations for changing, the desire to change sex varied widely among the men. Some genuinely were convinced they were women. Some expressed that they had an extreme desire to cross-dress that they couldn't control. And some had some form of body dysmorphia. However, for women who contacted Dr. Hamburger, the reason was always the same. The women were all same-sex attracted. They did not have any significant distress with their body, and instead they wanted, and I quote, to be able to marry their female friend. So, following the publication of Christine Jorgensen's story, the demand for gender reassignment began to increase rapidly worldwide. And an international network of clinicians was formed to help these patients. The demand from the United States played a very important role in the formation of this network, and this has to do with the difference in the laws in the United States versus Europe. In the United States at the time, castration was an illegal practice, whereas in Europe, castrations were not only legal, but were somewhat commonly performed on sex offenders, sometimes on individuals that wish to be rid of their homosexual tendencies, and for some other reasons. Those were all voluntary castrations, but they were common in Europe. So Europe already had a ready network of skilled surgeons, and so patients from the United States, who are primarily male, would travel to Europe for the first step of the procedure, which was referred to as demasculinization, and then they would come back to the United States to complete the second part, which is vaginoplasty, which is what US surgeons became very good at. Eventually, the Netherlands became the international center or the main hub, really, for gender transitions. And there's several reasons for this. One was that it became covered by their national health insurance. And in fact, the doctors were encouraging the citizens of Netherlands to reduce their working hours in order to qualify for insurance. But really, a really big reason was that the care was placed in a Christian hospital. And this is very, very important because it was a major hospital, highly respected Christian hospital. And it was not easy to convince the hospital's ethics committee that cutting into a healthy body was acceptable by medical ethics standards. And so the main plastic surgeon who was behind those procedures, who was doing these procedures in the Netherlands, who was also a Christian and highly respected in the Christian community, made an argument that was rooted in the Christian medical ethics. So this is a direct quote from Dr. Baumann, the plastic surgeon. From a Christian point of view, the soul, the psyche, should be considered more important than the body. So, if the soul is so disturbed that it makes people feel totally unhappy and get into trouble, it is allowed to help them in this way. So the Netherlands quickly acquired a significant volume of patients, and they were soon in the position to report on the outcomes. So in 1988, roughly 15 years after the practice was officially launched and became covered by the Dutch health system, the first outcome study was published. Even though it was a 15-year, the study was published 15 years later, in reality it was only a 2 to 5 year follow-up on average after the patient started hormones. There was also a very significant dropout rate, 38%. By the way, a few years later, when the same cohort was followed up on again, the dropout rate increased to 70%. The study reported on subjective measures, and the authors made a strong argument that subjective measures should really trump any objective measures because gender dysphoria is also a subjective feeling that cannot be objectively demonstrated. So the patients were asked questions such as, how happy or unhappy are you feeling currently? Do you ever have doubts about your sense of being a man or a woman? How satisfied are you with your own behavior as a man or a woman? And this is for transitioning patients. So, what the study found was that the patients who did participate in the research, and again there was significant dropout, they actually were quite happy with their transition. However, there were two major problems that emerged from the study. The first one is that although the patients said they were happy, their actual life situation did not always improve. And that was the actual quote from the study, that the actual life situation improvements were not always observed. And this became apparent when the researchers looked at supplementary data such as employment, partnership, a sense of loneliness, etc. The second problematic finding that the authors themselves called out was a really puzzling finding that these subjective feelings of satisfaction with transition in no way correlated with the phase of the transition for the patient. So patients who were just about to start cross-sex hormones were just as happy as patients who were midway through the treatment and were just as happy as patients who already underwent surgery. And this was very counterintuitive. The researchers wondered, are the patients really satisfied with their life, or are they taking a loan on the future and engaging in wishful thinking? And those were all the words from the Dutch authors, not from me. The authors also noted something that they themselves called a critical signal. There was a very high rate of attempted suicides after the transition was initiated. So the conclusion of the study was not all that optimistic. In fact, it was pretty sobering. Sex reassignment surgery is no panacea. This is directly from the study. Alleviation of the gender problems does not automatically lead to a happy and a lighthearted life. On the contrary, sex reassignment surgery can lead to new problems. In fact, one of the main physicians endocrinologists who oversaw the treatment paraphrased these findings in this way. The treatment does not solve the basic problem fundamentally, but a more bearable way of living is reached. So, within a year of publishing these outcomes, the Netherlands launched the practice of youth gender transitions. How did this leap from such problematic adult findings to youth happen? I think it's anybody's guess. I have a guess, having read a few studies. Actually, the subpar or the problematic findings in the Dutch research of adults were used to justify the practice for youth. In fact, they said, okay, the gender dysphoria resolved in the way that they define gender dysphoria. However, other problems didn't get better, so we're treating this too late. We need to start sooner. To provide more justification for this, they noted that younger patients seemed to do better. Although adults didn't do very well in these functioning measures like relationships and employment, younger patients did do better. And therefore, younger patients should therefore transition. But I want to ask an audience participation question. Can you make another guess for why younger patients did better, as opposed to they just started the process earlier and therefore are more functioning? Can one person shout it very loudly? Okay, the answer is right on the slide. The younger patients were female. Females, on average, develop gender dysphoria or present for gender dysphoria 5 to 10 years before men. And so if you think about what Dr. Hamburger said, the female patients were not confused about being in the wrong body. They weren't even terribly distressed by their body. They were high-functioning, young, same-sex attracted women who wanted to transition so that they could marry their girlfriends. And so it is quite likely that what was understood to be the benefits of early gender transition was really simply an observation that there are very different patients, different clusters of patients who wish to transition, and females who transitioned at the time were very mentally stable, were very high functioning, and had a very pragmatic goal for the transition. So, moving on to but you know, it's easy to say that, okay, this study was just misinterpreted and it's misinterpretation. In some way, this would be giving a lot of credit to the process because it would mean that the adult data was truly analyzed and informed the decision to start youth. I believe it was more of a hindsight reasoning to point to the poor outcomes of adults and say, well, that means we need to start earlier. The real reason is that history, I think, is very messy and is full of chance and happenstance. And so there are two completely chance events that probably actually led to the launch of youth transitions. One of them was that the psychologist who was working with transitioning adults, Dr. Peggy Cohen-Catenes, was transferred to the Children's Division of the hospital. And she herself says that when she was transferred, she did not think she would ever encounter another transsexual patient. Transsexual was a term at that time. But as soon as she transferred to Children's Division, she began to get a lot of referrals for children who seemingly had similar problems, referrals from her colleagues. And so it is interesting that it is quite clear that Peggy Cohen-Catenes' experience with adults really colored her perception of what she saw when she met these children. These are her own words. These were born girls who lived as boys with whom I had hit a wall with therapy, simply because there was nothing left to achieve. Their stories were crystal clear. They had a male gender identity, and all they wanted was to start treatment. The social indicators were positive. The only problem was that they hadn't reached the age of 18 yet. And then Dr. Cohen-Katenis adds, I myself had faith in it. I based that on the adolescents themselves. They were clear-headed, level-headed adolescents. And so this is how the decision to start youth gender transitions was made. Initially, it was simply lowering the age of 18 to the age of 16 for cross-sex hormones. Puberty blockers were not yet in the picture. A few years later, a second coincidence or happenstance occurred. Dr. Peggy Cohen-Katenis, who is a psychologist, in a hospital cafeteria, apparently, meets an endocrinologist, Dr. Henriette Delamar. In a conversation, they discover that the endocrinologist, in her own practice, is already treating a patient, which we now many refer to as patient 0. And this patient, she shares, was a masculine girl, 12-year-old masculine girl, growing up in a family with an Italian father who was not amused by his daughter's masculinity and had a really hard time accepting it. The girl herself, according to Peggy Cohen-Katenis, had an obsessive fear of puberty. The endocrinologist was already working with puberty blockers, which were relatively new treatment back then for central precocious puberty. And so she knew that this girl would become eligible for gender transition at 16 once she reached Peggy Cohen-Katenis' clinic at 16, but there was this gap. There's this 3-4 years to cover when the girl had this obsessive fear of puberty, and she had a brilliant idea to give her puberty blockers. And so by the time the patient at 16 meets Peggy Cohen-Katenis to start transition, she is struck by his, and these are her words, by his boyish appearance. She's so impressed and taken by his boyish appearance and his lack of breasts because he never went through female puberty. And so that was the moment that the Dutch protocol was likely born, or if not born, at the very least conceived. That was the patient 0 case that led these two doctors to begin to collaborate and to begin to transition cases, the constant trickle of referral of cases with puberty blockers. So you all know the Dutch protocol, so I won't belabor this. It's very important to say that there were very strict criteria. The strict criteria were articulated by the Dutch team for a clearly stated reason. They were very concerned with wrongfully transitioning minors who would later regret it. And so they came up with these clinical criteria based on their observation of the kids that they thought would likely benefit. However, there was another reason. This, and the Dutch team knew this from the very beginning, that they would need research to prove what they were doing. This was a proof of concept study, so it was very important to have only the best cases be in the study. Dr. Cohen-Katenis, again, speaks openly about this, and I quote from her, "I spent a lot of time with them, talked extensively with them, and again, I repeat a bit, these were clear-headed, level-headed adolescents who were able to properly think about themselves. That was important because I had to sell it to prove that it worked." And in fact, the proof came a few years later in the form of the two studies that many refer to as the Dutch studies. There's a 2011 study and the 2014 study. Again, I will very briefly speak about these studies. The 2011 study had 70 cases in it. and the outcomes were pretty, I would say, not terribly significant, and the conclusions were pretty mild. And you can read the conclusions. And the 2014 study was a subset of the 70 cases. It shrank to 55. Again, it was a relatively short-term study, uncontrolled. And again, the conclusions are not all that earth-shattering, in contrast to how these studies have been positioned as the gold standard. Our study focused on the limitation. Our study, The Myth of Reliable Research, does go in detail. I will not talk about all the limitations, only a couple of limitations that I think are really important to understand. The lack of applicability of the Dutch studies to the current patient cohort should have been self-evident from the very beginning. And in fact, when we realized that the very youth that are being transitioned today were explicitly disqualified from the transition, this all should have been immediately put on pause and reevaluated. But this is not what happened. However, there is another really big problem that few people understand, and because I really, really geek out on data, I would love for you to understand the problem with a case selection study, with a case selection. Because even if you set aside the notion that we're now transitioning the population of kids that should have never been transitioned with this because they were explicitly disqualified from the research, it still leaves the question of what about these classic Dutch kids, early onset gender dysphoria? Well, as it turns out, the study isn't really representative of the outcomes for these kids either, and this is because of how the cases were selected. So again, I'm not talking about now the adolescent onset versus early onset. I'm talking about the early onset children. And so the analogy I'd like to make is, so essentially the problem is that Dutch used the start date of the cross-sex hormones in order to select cases for inclusion in the puberty blocker study. And I know it probably sounds convoluted, so I came up with an analogy while I was sitting here a few minutes ago. So if you know of a triathlon, it's an event that has 3 stages: swim, bike, and run. And so let's imagine that, so each person who enters it is supposed to enter all the 3 phases, or finish all the 3 phases. So suppose you wanted to understand the results of the first phase, the swim, but instead of taking all the swimmers and reporting on their outcomes, you would take the first 50 of those who came out of or the first 70 of those who already finished their swim, got on their bike gears, and started riding their bikes. Now, that's the subset that now you turn back and say, let's see what their swim times are. Let's see how well they're feeling. Let's see how well this is doing. You can imagine what this analysis would leave out. It would leave out all the weak swimmers. It would also leave out if anybody drowned, because there's no way you could get on a bike, okay? Or anybody who dropped out, who basically just finished and said, I can't do this, okay? So this is one of the most problematic areas of the Dutch studies that I think is underappreciated, that the research into puberty blockers was not based on the cases that started puberty blockers. It was based on the cases that started cross-sex hormones, which means the first 70, which means anybody who had some problems with puberty blockers, so they were not quite approved for the next phase of treatment, or anybody who had problems would not have been in. And this is perhaps why when the UK clinic tried to replicate the Dutch study, it failed replication because they actually included all of the swimmers instead of all of the bikers. I'll flip through this slide quickly. There was actually half of the outcomes were not statistically significant, and the other half were of marginal clinical significance. And this is really remarkable. There is a missing study on cross-sex hormones. If you really think about this, there is no explanation for it. Nobody has asked any questions about it. But today, for every 1 person who is treated with puberty blockers, 15 are treated with cross-sex hormones. That's from Reuters, only cross-sex hormones. So why was the cross-sex hormone outcome study not published? What we know is clearly some patients got harmed in the process, but this is more of a footnote in the study than a separate analysis. And of course, the main study has all of the biases of the other study because it's just a subset of the cases, and it has a major additional new problem that it introduced. The really main finding is the complete resolution of gender dysphoria. That's really the hallmark, the linchpin finding of the Dutch research. But as we described in our research, this is actually a very problematic finding, and so I just invite you to do a quick thought exercise to see how this finding, which we think is invalid, was achieved. Each individual had to answer 2 scales, 2 sets of questionnaires. Before, the questionnaire was based on sex, after based on gender identity. So if you were a gender dysphoric female, imagine how you would answer for example, the second question. Every time someone treats me like a girl, I feel hurt. Most gender dysphoric females would say, yes, I'm hurt, and get the highest gender dysphoria score. After the surgery, they get the question, every time someone treats me like a boy, I'm hurt, I feel hurt. Of course, that individual would not. They want to be treated as a boy. They always have wanted. So we argued that this is just, even though mathematically that shows a complete resolution of dysphoria from maximum score to minimum score, in reality, the patient is answering the question in the same way, consistently. It's just a linguistic inversion and inversion in mathematical scoring, and if both sets of questions were given right before treatment started, gender dysphoria would have already been resolved. And then to add, gender dysphoric females before would have to answer question, I hate menstruating because it makes me feel like a girl. A lot of them would say yes. Afterwards, they would get a question, I dislike having erections. Most gender dysphoric females would not say, I dislike having erections, for more than one reason. We're not the only ones who see profound problems with the Dutch research. The NICE systematic review of evidence also considered them providing very low quality evidence, and the final main study was actually completely excluded from the research because it conflated psychotherapy with all the other interventions. And so I want to finish with a quote from our study with, again, Dr. Levine and Dr. Mason. There is no doubt that puberty blockers, cross-sex hormones, can powerfully transform a body. There's also no doubt that this is a pathway toward chemical sterility, and that most children who start puberty blockers proceed with cross-sex hormones. So yes, we do have the medical technology to transform adolescent bodies, but the real question is, just because we can, should we? Thank you.